So here we are, and so I'm going to talk about the major developments which have taken place, how the hip replacement came into being, and what are the changes, and what are the future changes we are looking at. So it's going to be a little hurried talk, but don't mind, because the idea is to give you an overview, not to teach you, but to sensitize you, and so that you are actually conversant with the terms which are of relevance. It has been the operation of the century, there's no doubt about it, and it actually gives tremendous relief to the patient, and it has moved through evolution like most other technologies which have developed over a period of time. And what I'm going to tell you now is how we have traveled through the time with this technology. It all started with the interpositional arthroplasty, when we realized that pain relief could be given by interposing some kind of material between the hip joint. And of course, the patient was left with a bad hip, which was badly, which was shortened and didn't give the enough function. Then the hemiarthroplasty came from Jude, followed by the other types which are more familiar. Then the Vitalium cup interposition arthroplasty was given by Smith-Peterson in 1938. Then the Phillips-Wiles was made an implant which was really the precedent of the modern generation. McIfrar made a metal-on-metal articulation and fixed the components with cement. Then Peter Ring, who did not believe in the cement fixation, developed self-locking implants and again gave a metal-on-metal articulation. But the real revolution came with Sir John Charnley, who gave three ideas: the low-friction arthroplasty, the use of cement, as well as the high-density polyethylene as a bearing material. And then these hips lasted for very good time, even 25 years in about 80% patients. But the failures continued because I think we needed improvements in materials. Although the Charnley recommended only for the elderly and infirm people, we wanted to use it for the younger people. So the entire advancement in the total hip was directed at reducing the rates of failure, accommodating the high activity profile, increasing the longevity of the modern patient, expecting the implant to last longer, durable fixation, and the newer bearing materials. So the cementing was started by Gluck, and then Charnley introduced the use of polymethyl methacrylate, and then we realized that, and many parts of the world think that possibly the cement fixation is the holy grail for fixation. The cementing itself has undergone changes from first generation to third generation, but what has changed is not the cement, but the way it is used, and that is actually preparing a really good bed, and these newer generation techniques have shown increased longevity. About the design of the cemented stems, there are essentially two designs: the taper slip and the composite beam. The taper slip is highly polished taper stem which settles within the cement mantle and re-engages the taper and distributes the load by converting these shear stresses to hoop stresses. The composite beam, on the other hand, is a shape-closed design, and both have been initially shown to have good survivorship, but Exeter, a 10-year, 100% survivorship in this paper by William et al. Then the Wroblewski introduced the third taper, which is called the C-stem by the GPU, and that was supposed to improve the loading, and the initial studies show 100% survivorship. So some sort of taper design, but then whenever there was an attempt to idea from one side to other, it was a disaster. So when this highly polished surface was changed to the matted surface in the cemented stem, it led to a catastrophic failure. The people started getting worried about what they thought was the cement disease, so they went on to the cementless fixation with the advantages of immediate press fit stability and the advantage of... No? Don't mind saying another 10 minutes? Okay. Thank you. Thank you. So, okay. So it's the cementless fixation was introduced with the object of immediate press fit stability, durable fixation, that a young patient, you could do it and look at a lifelong solution. Then it was, of course, biomechanical compatibility was there. We thought we could avoid the thigh pain and stress protection. So the flaw in the earlier cementless designs was that they were cylindrical. So there was a fixation all through the shaft, which led to the stress shielding as well as thigh pain. And then that cortical atrophy and bone loss was actually didn't augur well for the future revisions. Then another experimentation which was done was whether to use the intermittent proximal coating, which actually allowed wear particles to travel through the voids within the coating, and it was then decided that possibly the circumferential proximal porous coated stem designs are the way to go. So all cementless stems either rely on these metaphases, diaphases, or a combination of these. So this was a classification of the different types of stems which are available, but essentially they could be divided into three types: the anatomical, the tapered, and the cylindrical. And the tapered stems are the ones which have stood the test of time and now are known to be the gold standard, because they give 3-point fixation and the thigh pain is largely eliminated. The biggest technical advantage is that if you prepare anesthesia and pain relief and post-op rehabilitation. So these developments have taken place to reduce the tissue trauma during surgery, to improve the activities which you allow to patient after the surgery, to make the surgery reproducible, to reduce the mobility, the incision length is reduced, the mobilization is much faster, the blood transfusion is close to minimal in the primary total hip, the pain, there's an attempt to reduce it to minimum, the activities which are permitted have been increased and are a wider range, the hospital stay has been reduced. I'm going to talk about the daycare surgery, and the lifespan of the implants has actually increased. So basically this is the result of years of research by orthopedic surgeons, biomechanical engineers, and material technologists, and then you can extend this benefit to the younger patients as well. This example, classically our younger patients who are now actually have to be converted from fused hips to mobile hips, which has also brought to the fore the problem about the spinopelvic deformities having their impact on the hip. So what has been realized lately is that patients who have undergone hip replacement, if they need a spine surgery because of the degenerative spine, they could actually lead to an instability in a hip which was previously stable. So more and more emphasis is paid on the impact of the pelvic incidence, sacral tilt, and those parameters on the stability of the hip, because they have impact. Similarly, we have a Welcome Trust project with Dr. Deepak here, where we are actually making CAD models of these spinopelvic deformities to see which way we have to alter the orientation of acetabular components so that we can have a stable hip. And the cementless hips have become, in spite of the widespread resistance from many corners of the world, it has become the standard of care, because that actually gives rise to a long-standing fixation. The implant designs have allowed us to reduce the wear rates, and foremost among them has been highly cross-linked polyethylene, which has been a game changer. And that actually reduces the wear so much that you can actually really even offer it to the young patient. So this game changer has actually brought back the popularity of the polyethylene, and when we started facing challenges with the hard bearing, the highly cross-linked polyethylene still comes to our rescue. The ceramic on ceramic does have low wear rate as compared to any other bearing with polyethylene, and it has got many other advantages for a bearing surface, as we all know. But then the disadvantages for this are, if you put it vertically, you could cause a stripe wear, or you can cause impingement, and it could actually lead to fracture if you use the smaller size. So the modern bearing surfaces have allowed us to reduce the wear to a great extent, and that has been one of the most remarkable advances. The another material is oxenium, which actually has got all the properties of the ceramic. And the advantage of oxenium over the ceramic is that it doesn't fracture, and that it does allow you a much greater range and variety of the head sizes. However, the problem is that if you damage the oxenium during the implantation, then it can lead to the catastrophic wear. The femoral head size has been debated and has finally trickled somewhere to around 32 size. We know that the ideal hip size restores the hip biomechanics, makes it stable, balances the soft tissues, and reduces the polyethylene wear, and also prevents the tendinosis. So that actually the concept of stability brought to the fore, again another concept which is a dual mobility. What started in Europe and France essentially has now finally reached the US also, and then this is actually an extremely useful technology to reduce the increased risk of dislocation in elderly. So an elderly person with a fractured neck femur today will be actually benefit a lot from implantation of a dual mobility cup. although there are certain reports of